Good evening once again and welcome back. This is teleconferencing program and this is our fourth and second last session of today's program. This program is specially designed for DNB students and this is our teleconferencing program which is a live phone-in program. Yes, you can be a part of this program through your phone calls and to make a phone call you will have to know the topic of this session. The topic of this session is pneumonia in the immunocompromised host and the expert of our this session is Dr. N.K. Gupta. Dr. N.K. Gupta is on the extreme left of mine. Dr. N.K. Gupta is senior chest physician in Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. We also have Dr. T.K. Jaina with us, who is next to Dr. N.K. Gupta. Dr. T.K. Jaina is from School of Health Sciences, Indira Gandhi National Open University. Both are welcome in our program, but before hand over the program to Dr. N.K. Gupta, I would like to tell you the phone numbers of our program so that you may make a phone call to ask your queries. The numbers would be same. Before dialing the numbers, you will have to affix 011 if you are dialing from outside Delhi, and the numbers are flashing on your screens also, 29532844 and 29532845. You can use our toll free number also, that is 1800112345. To download the forms of National Board of Examination, you can visit our website. Website is www.netboard.edu.in. www.natboard.edu.in, and if you want to get the DVDs of teleconferencing programs, you can contact National Board of Examination. This is a live phone-in program. This is teleconferencing program, and this program is jointly conducted by Indira Gandhi National Open University and National Board of Examination. So right now I request Dr. N.K. Gupta to start the program about pneumonia in the immunocompromised host. Dr. Gupta, please.
Thank you. We will continue with the series on the pneumonias. We have already heard about the community-acquired pneumonia, severe pneumonia, hospital-acquired pneumonia. I am going to discuss about the pneumonia in the immunocompromised host. Now, we by this time have learned now how the host is actually defend itself against the various type of infections. There are physical barriers. Dr. Bhattacharya had discussed what are those barriers and how those barriers are invaded. There are other barriers like humoral immunities, cellular mechanisms like antibodies, polymorphonucleosides and lymphocytes, how the barrier is breached, how the germ actually causes pneumonia formation in the lungs, and how the pneumonia is classified, diagnosed, categorized and finally managed. Now, what is the importance in the immunocompromised host? Pneumonia in the immunocompromised host actually involves infection and the inflammation in the lower respiratory tract by unusual pathogens. The signs and symptoms depend upon the pathogens. The diagnosis needs aggressive approach because majority of these patients are actually immunocompromised. They have an underlying disorder. So the treatment depends on the host defect as well as on the pathogen itself. The importance is that regardless of the reasons for the altered immune functions, the pneumonia carries a very high mortality rates in these immunocompromised patients. What is a pathogen? We know pathogen is a microorganism which is causing the disease. A primary pathogen is the common cause of disease in the healthy non-immunocompromised host, for example like Staph pneumoniae, Staph aureus, etc. Now, opportunistic pathogens are the rare causes of disease in healthy individuals, but they cause serious disease in the compromised host. For example, like Pseudomonas aeruginosa. Now, if we just have an overview of the host defense is not just immunological. The anatomical integrity and the physiological defense of the body surfaces are very important. For example, integuments like skin, mucous membranes, the peristalsis, the mucociliary escalator system, normal flora, normal urinary flow, etc. And when these are compromised, for example, due to the damage to the physical defenses against infection by burns, by trauma, by breaching the skin like as we do under cannulations, iatrogenic damage to the physical defenses during surgery, foreign body insertions, intubations, urinary catheterizations, they actually leads to the damage to the physical defense against the infection. There could be other kind of defense disruptions like antimicrobials which disturbs the normal flora, or there could be cytotoxic damage during which causes the damage to the gut. Now, so what is the immunodeficiency? The primary immunodeficiency could be where there is a defect right from the birth. There could be neutrophil defect like in congenital granuloside defects. or deficiencies. There could be humoral defects like B cell defects. It could be a complement deficiency. It could be cell mediated T cell deficiencies, or there could be severe combined immunodeficiency. The immunodeficiency can also be acquired, that is secondary to, for example, like AIDS. It could be like neutropenia occurring in post-transplant patients, in bone marrow transplant patients, in chemotherapy patients, or patients who have been splenectomatized, that is, their spleen has been removed. Now, what is the importance in these patients whose immune system has been compromised? The aggressive tumors like leukemia, lymphoma, uncontrolled metastatic tumors, these are the subgroup of individuals who are highly susceptible to infections. Patients like having received recent hematopoietic stem cell transplantations recipients, or allogenic hematopoietic stem cell transplant recipients with significant growth versus host disorders. They could be recent infections with viruses like cytomegalovirus, or known colonization with fungi or resistant bacteria, or when the patient's absolute neutrophil count goes below 500 per microliter, or when there is a high dose corticosteroid usage or recent intensification of immune suppression. These subgroup of patients actually are highly susceptible to infection. There are various immune deficiency states. This is a list. We have the HIV infections, cystic fibrosis. There could be primary immunodeficiencies. They could be due to transplant immunosuppressions. Malignancies like leukemia, lymphoma itself can cause, or chemotherapy which is given to treat these malignancies. Alcoholics are particularly susceptible. Patient with the chronic steroid usage, autoimmune diseases, asplenic patients, functionally immunocompromised, extremes of ages, pregnancy, or burn. These are the immunodeficient states we are interested, because these are the one in which there is a risk of infection. What is the pathophysiology involved? Many pulmonary pathogens reliably plague the host with a dysfunctional immune system. What is the meaning of this is that patients with even the normal system or slightly dysfunctional immune system will reliably get pneumonias with the known agents like staph pneumoniae. But there are others which are encountered more frequently with certain causes of immune suppression. Therefore, the pathophysiology can be appreciated in both general terms and in more specific context as related to the specific underlying immune deficiency states. Conceptually, pneumonia susceptibility from immune suppression stems from either from the neutrophil defects, immunoglobulin defects, or T cell defects. The underlying reason for the immune suppressions, therefore, if we know, may suggest certain pulmonary pathology. For example, in primary immunodeficiency states, the pathogens could be, for example, if there is a humoral defect, then the pathogens are likely to be capsulated bacteria like staph pneumoniae, H. influenzae, Neisseria meningitidis, Staph aureus, or enterovirus or mycoplasma. If there is a specific neutrophil defect, then Staph aureus, Candida, or Aspergillus are more likely. If there is a cell-mediated defect, then intracellular bacteria like Mycobacteria, Salmonella, Listeria, Legionella, or viruses like herpes, respiratory RSVs, or enteric viruses, and or fungi and protozoa like Candida, Aspergillus, Pneumocystis carinii, Cryptococcus, Cryptosporidium, or Toxoplasma. These are the ones which will affect those having cell-mediated defect. So, it is important to understand what are the pathophysiological mechanism underlying various diseases. For example, malignancy. Now, in malignancy, there could be a neutrophil defect, immunoglobulin defect, or a T cell defect, and they are all seen in patients with cancer. Cancer patients are also being given chemotherapy, and many treatment protocols exist. Common adverse reactions are leukopenia and lymphopenia, and they make the patient susceptible to various infections. Or there could be underlying immune dysfunction itself, which is due to the malignancy per se. What is the mechanism in AIDS? The T cell dysfunction in the setting of HIV leads to a number of infectious complications. HIV causes dysfunction of cell-mediated as well as humoral immunity. CD4 T cell count or CD4 T cells principally helps other cells achieve their effector function, and as such, at low CD4 levels, a disruption of B cell differentiation occurs. This leads to, that means impaired B cell function leads to memory cells defects, and which are postulated to account for the increased risk of infection. In the case of Pneumocystis jirovecii infection, HIV has been thought to represent actual reactivation of the latent colonization. We will come to them subsequently. If there is an acquired immunodeficiency like neutropenia, this causes could be due to like post chemotherapy or post bone marrow transplantations. It could be due to aplastic pneumonia, like for example due to drugs like chlorphenicol, or sometimes high doses of beta lactams can lead to neutropenia. When we give chemotherapy, cytotoxic effect of this chemotherapy causes the fall in the neutropenia, and there is a progressive fall, the peak level being around about 8th day, and this is the crucial time when the level goes down to about 500 or below, then the risk of infections become maximum. In the transplant immunosuppressions, what is the pathophysiology involved? For both solid organ and bone marrow transplant patients, the time since transplant is a major predictor of infectious complications. Various induction regimes are used in the early post-transplant periods, and while maintenance therapies which are given for a long-term medications or long-term medication strategies actually can also lead to the dysfunctions of the immune status. Solid organ transplants, a variety of anti-lymphoproliferative agents are used commonly, which include cyclosporin, azathioprine and tacrolimus. Additionally, both monoclonal and polyclonal antibodies to hematopoietic antigens are increasingly being used. In bone marrow transplant, various anti-lymphoproliferative agents are being used, and these all lead to deficiencies of these cells. In pregnancy, a comparative deficiency exists, which results in immunological pregnancy actually results in immunologic changes that predisposes to infection. There is a decrease in the helper T cell numbers, there is a reduced activity of the natural killer cells, and decreased cell-mediated immune function. Further, there are cardiopulmonary changes that occur as a part of normal pregnancy, which may result in a diminished capacity to compensate for the effects of the respiratory disease, which may aggravate the symptomatology of the pneumonia. The elevated serum concentration of the progesterone and 17-beta estradiol has been observed in the later half of pregnancy, and this can stimulate the growth and maturation of coccidioides immitis. In cystic fibrosis, an abnormal chloride and sodium transport in the respiratory epithelium leads to thick viscous secretions. The chronic airway obstructions then leads to colonization by the pathogenic bacteria, especially Pseudomonas aeruginosa. In the autoimmune diseases, for example, systemic lupus erythematosus, infection versus autoimmune flare needs to be differentiated right at the outset. Sometimes there is an immune flare which may mimic an infection. The treatment with steroids in the setting of infection could also be deleterious, and this can lead to susceptibility to infectious derived from the therapeutic and the disease related factors. For example, there could be a complement deficiency, elevated Fc gamma 3 and granulate macrophage colony stimulating factor, that is GM-CSF, and these levels may contribute to increased susceptibility to infection. There are use of prednisolone, more than 20 mg prednisolone daily is also a risk factor, and the use of agents like cyclophosphamide, they can also be important in increasing the risk for the infections. Connective tissue diseases, both the primary condition and the use of immunosuppressive medications places the patients at increased risk of in a recent meta-analysis of about 5,400 cases reviewed, 29% of the patients developed serious infection and 24 actually died from this infection, mostly reported as bacteremia or pneumonia. In functionally immunocompromised, what is the meaning of functionally immunocompromised? Basically, the immune function is compromised due to certain disorders like neuromuscular diseases. Pneumonia is a leading cause of death. Impairment of cough and swelling mechanisms contribute to increased risk of pneumonia. Gastroesophageal reflux is more common, persistent and severe in patients with cerebral palsy. Kyphoscoliosis also causes atelectasis and can lead to the pneumonia formation. In cognitive dysfunctions, there is a drooling, feeding problem and aspiration, and this places these patients at higher risk of pulmonary infections. Asynchrony between swallowing and breathing also results in increased risk of aspirations. In patients having spinal cord injuries, muscular weakness may contribute to the dysfunctional cough reflex, and this promotes the infection formation. In extremes of ages, both old and the young are at increased risk of pneumonia. The older patients may complain of fewer symptoms than younger patients, making the diagnosis more challenging. Children and infants are at an increased risk of respiratory syncytial virus infections. It has been seen that younger than 24 months with chronic lung diseases who have required medical therapy within 6 months of RSV in season's onset, preterm infants born prior to 32 weeks gestation, or preterm infants born 30 to 35 weeks of gestation with at least 2 additional risk factors, and those with hemodynamically significant heart disease. These are the infants which are especially at the risk of developing RSV infection. This will be discussed more in detail in the next lecture. Burns. The complication arises from both direct lung injury and indirect pulmonary effects, that is decreased lung expansion secondary to circumferential burns. Now, the bacterial clearance is impaired in patients with inhalation injury. Mechanisms for impaired clearance include impaired cough, impaired mucociliary action, airway plugging, and impaired alveolar macrophage function. So, if there is a immunodeficient states, then what are the etiological agents which are specially involved? The etiological agents responsible for pneumonia in immunocompromised patients are often different than those found in the immunocompetent patients. Bacterial pneumonia are of course the leading. The common infections are always there, but infections like tuberculosis, coccidioides species, cytomegalovirus, histoplasma species, aspergillus species, Mycobacterium avium intracellular complex, PCP pneumonia, influenza, HSV, varicella zoster, Legionella, nocardia, Cryptococcus, Mucorrhizae, Strongyloides species, Toxoplasma, and Canopocytophaga species have been noted. The causative agents, therefore, may be variable in various immunosuppressive states. Let us discuss what happens in HIV. In HIV, the rate of bacterial pneumonia is higher in HIV positive patients than matched HIV negative control at all CD4 levels. Therefore, bacterial pneumonia still remains very high. Staph pneumoniae is the most commonly identified bacterial pathogen. Their risk of pneumonia is 10 to 100 times greater than non-HIV infected patients. It is not that if only opportunistic infections occurs in HIV, common infections are equally important. Globally, 11.4 million adults between the age of 15 to 49 years are co-infected with HIV and TB. So therefore, TB also is one of the very important factors, especially in African countries. And PCP remains a leading cause of death in patients with HIV. So therefore, not only bacterial pneumonias, but there are other opportunistic infections which become very important as the patient's immune status falls. The fungi like Pneumocystis carinii, Candida, Cryptococcus, parasites like cerebral toxoplasmosis or cryptosporidisis, bacteria like Mycobacterium avium intracellular complex, Mycobacterium tuberculosis or Salmonella, and viruses like CMV, HSV, etc. They are equally common. But there is a rider. The arrival of highly active antiretroviral therapy or HRT has led to stunning decline in the incidence of these infections in the HIV patients. There is a direct association which occurs between the opportunistic infections and the CD4 lymphocytic count. It has been seen that if the lymphocytic count, CD4 count is on the higher side, only infections like viral herpes zoster occur. But as the count goes down, tuberculosis at 350, oral candidiasis at 300, when the count goes down to 200, Pneumocystis carinii pneumonia, esophageal candidiasis and mucocutaneous herpes are seen. But as the count goes down further to 100, then the Toxoplasma, Cryptococcus, Mycobacterium avium intracellular complexes, cytomegaloviruses, and ultimately cryptosporidisis, etc. are seen. So, what is the important factors about the opportunistic infections with HIV? They are caused by the defects in cell-mediated immunity. So, the common viral and bacterial infections are not increased as is expected, but staph pneumoniae and salmonella are common. Nearly all opportunistic infections responds to HART, H-A-R-T, exception being progressive multifocal leukoencephalopathy. But there is also another important phenomena which occurs when there is a reconstitution of the immune system. This is called immune reconstitution inflammatory syndrome. Paradoxical, this leads to an illness which is associated with the improving immunity. As the CD4 count improves following the induction HART, there is a rebound phenomena and there is a flare-up. But the treatment remains that the HRT needs to be continued along with steroids. we may discuss certain specific infections like pneumocystis. Basically, earlier it was called Carani, but now the name is Girovici. It's an ubiquitous, uncultivable fungus, which is an opportunistic pathogen. 60% of the people actually become infected by the age of 4 years. There is a complex life cycle which involves cysts and the trophozoites, and this is one of the most common infection in the AIDS. Its presentation is usually insidious. There is a non-productive cough, breathlessness, fever. If you take a chest röntgenogram like the X-ray shown here, there could be a perihilar infiltrates which may progress to severe respiratory distress, and there could be extrapulmonary infections. The diagnosis is usually by the methenamine silver stains obtained done on the fluids obtained either by the BAL or the biopsy. We can do a monoclonal antibody detection. The treatment is high dose cotrimazole sulfamethoxyl combination. Patient may need a ventilation support. Steroids are given and has been found to be helpful in treating. If sulfonamide allergy occurs, then the pentamidine, dapsone, or clindamycin plus primaquine, atabacone, etc. has been given. In AIDS patient, as the patient's CD4 count is falling, there is a need for the primary prophylaxis to prevent this particular problem of PCP. When the count is less than 350, or there is a WHO stage 2, 3 and 4 in HIV, or there is associated oral candidiasis, or there is unexplained fever, the patient needs to be put on the cotrimoxazole prophylaxis. Secondary prophylaxis is also required to prevent recurrence in those patients who have a prior episode of PCP. The standard regimen is, or alternatively use dapsone, but cotrimoxazole is more effective than dapsone for preventing PCP because it also prevents toxoplasmosis, listeria, staph pneumoniae, staph aureus and legionella, etc. The duration, it can be lifelong, but it may be discontinued if the immune system is restored. The patient must have a CD4 count of more than 250 for at least 3 months. The another common problem in HIV infected person is a Mycobacterium tuberculosis. There is a 2 to 10% annual risk of infection if the patient is HIV positive. Worldwide, most illness actually is a reactivation of the latent infection,